I'll be the moderator for this virtual program. I want to welcome you to today's speaker program. In consideration of the audience and the speaker, I have muted all attendee phone lines. Should you need a copy of the PI, there is a link to AstraZeneca's PI Central site. Simply click on the link, navigate to the product, and download the PI. Good afternoon, everyone. I'm Charles, and I'll be the moderator for this virtual program, and I want to welcome you to today's speaker program. In consideration of the audience and the speaker, I have muted all attendee phone lines. Should you need a copy of the PI, there is a link to AstraZeneca's PI Central site. Simply click on the link, navigate to the product, and download the PI. At this time, I would like to introduce our host, Kathy, for some announcements.
Thank you, Charles. Before we begin tonight, I do have a few housekeeping items to address. So AstraZeneca is the sponsor of the program, and the speakers are presenting on behalf of AstraZeneca this evening. We do welcome all of your questions. You can put your questions in the Q&A pod on your screen as they come up, and we will answer those at the end of the program. If you have something that you would like to ask live, you can simply raise your hand and Charles will unmute your line and you'll be able to ask your question. Tonight, we will only be able to answer on-label questions, and any off-label questions will be submitted to AZ Medical Information for a response. So I want to take this time to thank all of you for joining us this evening. I think you'll find the information being presented this evening to be extremely valuable and also practice changing. I also wanted to take this time to recognize each of you and thank you for your commitment to your patients. We know that 2020 was a challenging year, to say the least, and 2021 is starting out that way also. And so we want to say thank you for your dedication to your patients. It certainly has not gone unnoticed, and AstraZeneca wants to thank each and every one of you. So now I'd like to take the time to introduce our speakers for this evening. Our first speaker is Dr. Young Che. Dr. Che received his medical degree from Seoul National University in South Korea and a master's degree in public health and business administration from Johns Hopkins University, Bloomberg School of Public Health, and the Carey Business School, respectively, both in Baltimore. He completed his residency in internal medicine at Albert Einstein Medical Center in Philadelphia and a fellowship in hematology and oncology at the University of Texas MD Anderson Cancer Center in Houston. Dr. Che is board certified in internal medicine and medical oncology and is assistant professor of medicine at Northwestern University Feinberg School of Medicine. Dr. Che is participating in 18 ongoing clinical trials and has published over 50 articles in peer-reviewed journals. Our next speaker is Dr. Jeffrey Lamb. Dr. Lamb is a double board certified cardiothoracic surgeon. Dr. Lamb earned his medical degree from John A. Burns School of Medicine, University of Hawaii at Manoa and Honolulu. He completed his residency in general surgery at Emory University School of Medicine in Atlanta and his fellowship in cardiothoracic surgery at New York University School of Medicine. Dr. Lamb's clinical interests include minimally invasive and robotic thoracic surgery for the treatment of lung cancer, mediastinal tumors, benign esophageal disease, and esophageal cancer. Dr. Lamb practices at Spectrum Health Medical Group Cardiothoracic Surgery in Grand Rapids, Michigan. Welcome, Dr. Che and Dr. Lamb. And at this time, we will begin our program, and I will turn the stage over to Dr. Che.
Thank you for the kind introduction. So I'm a thoracic medical oncologist. practicing in Chicago. We'll be talking about the resectable and metastatic non-small cell lung cancer with EGFR exon 19 deletion and exon 21 L858R mutation. Those are the two classic mutations. Next.
All right, there we go. Sorry.
I guess the disclaimer slide was this is not CME accredited and this is sponsored by AZ, and will not talk about off-label use. So current indication as it is in the FDA approval language is it is approved for adjuvant treatment of EGFR mutation positive non-small cell lung cancer for two classic mutations, and then first-line treatment for EGFR mutation positive metastatic lung cancer, and then previously treated EGFR T790M mutation positive metastatic lung cancer. Those are the three very different indications, and the most recent one is one on the top. Next slide. Can we go next?
I'm sorry, it's not advancing. There we go. Sorry about that.
That's okay. So as you can see at the bottom, the metastatic disease, we've been making progress in terms of having more targets for targeted therapy options. But in the resectable disease space, since 2005, where cisplatin doublet chemotherapy developed, we did not have anything until last year when adjuvant osimertinib was officially approved. Next slide. And Tagrisso has consistently advanced the standard of care with patients who has EGFR mutation. So the history is 2005, we had the first T790M approval. This is the AURA trial, and FLORA is what made Tagrisso frontline. 2018, 2019, there's a mature overall survival data that was presented. And 2020 is when we got the first and only EGFR TKI option approved for completely resected non-small cell lung cancer. In December is when we got the approval for this indication from FDA. Next slide. So we're going to talk about this Tagrisso indication in the resectable tumor with EGFR. Next slide. So I think we can have Dr. Lam talk a bit more about this resectable space, and I can take over when we get to more like medication section. Next slide. There's still a slide about, so adjuvant options are present for different type of cancers, and as you can see, in breast and colon they've been making progress, melanoma, but lung cancer really no progress over 15 years. Next slide. Yeah, and maybe Dr. Lam can take over from this slide.
Sure. Thank you, Dr. Che. And again, to Kathy and all of AstraZeneca, thank you very much for this opportunity, and thank you for that kind introduction. So I'm a thoracic surgeon. About 80% of my practice is taking care of patients with lung cancer and lung disease. And as we know, lung cancer is a terrible, terrible disease. It accounts for more deaths than colon cancer, breast cancer, and prostate cancer combined in this country. I'm fortunate that I get to see patients with earlier disease. I see patients that have the potentially resectable, potentially curable disease, but that's only about 30% of all patients with non-small cell lung cancer. Unfortunately, 70% of them present at a later stage and are not candidates for surgery. And so I tend to see the more fortunate ones, patients that either have localized early stage 1 disease or patients that either have a more advanced tumor or local nodal disease, which is stage 2 or stage 3. But again, of the more than 50,000 patients a year in this country that are diagnosed, only about 30% of them ever come to my office because those are the ones that have potentially resectable disease. Next slide, please. And when looking at traditional, conventional adjuvant chemotherapy, patients that are resectable with stage 1B, oh, I'm sorry, yeah, can you go back? Yes, stage 1B, stage 2 or stage 3 disease, within 5 years, you can see the rate of recurrence for these patients, and it's not great. And this is even after surgery. So the best case scenario is the early stage 1B disease, and even about half of those, 45% of them, will have a 5-year rate of either recurrence or death. And it only gets worse as you go up the stages to stage 2 or stage 3. And so if you look at all those patients combined, about 40% of them treated with adjuvant chemotherapy will recur and have metastatic disease. So there's obviously a great need for something in addition to or instead of traditional adjuvant chemotherapy, because this is still a disease that we're fighting, and it's still a very terrible disease in this country. Next slide, please. So we have a question for the audience. And the question for you folks is, based on your experience with your patients, how do you feel the 5-year rates of recurrence or death align? As I had mentioned, about 45% recurrence or death within 5 years for stage 1B, and then 62% for stage 2, 76% for stage 3. Do you feel that your patients have that same survival? Do they do worse than that, better than that? So this would be an audience question. Kathy, are we somehow collecting that poll with that information?
I'm not actually sure, Dr. Lamb. I don't see anything in the Q&A at all, or
Okay.
anything in the chat. So why don't we just go ahead and go on?
Okay, so something to consider, going forward, and we'll move on.
Okay, so now it's stuck again. There we go.
Okay. And as Dr. Che had mentioned, looking at all the different potential driver mutations, we focus on EGFR mutations as this hidden, often undiagnosed driver. And so even after surgery is successful, and by that, as a surgeon, we think about having negative margins, we think about a complete R0 resection, and we think about having an adequate lymph node sampling. And despite all that, we may still miss micrometastatic disease that we can't even see on initial staging CT or PET scans. And then looking at data, the initial recurrence happens in about 40% of patients at any number of sites. And this graphic right here shows you the common areas of recurrence. You may have distant recurrence in the liver, bone, or brain. And you can also have local recurrence, either within the same lung, within nodal disease, or the contralateral lung. And so this is what we're trying to target. We don't know what patients may have micrometastatic disease that's undiagnosed and not seen on initial imaging pre-op. And after surgery, we need some way of helping these patients before they actually recur on subsequent surveillance imaging. Dr. Che, I think I'll pass off to you.
So here we have EGFR mutation prevalence across different stages. So the bottom line is they are very similar across different stages, and still remaining as the key driver. Next slide. Next slide.
Sorry, it sticks sometimes here for some reason. There we go.
Okay.
Thank you.
No problem. What percentage of patients with resectable non-small cell lung cancer in your practice currently undergo molecular testing? This would have been good for Paul, but I think I can tell you my institution experiences. We have reflex tests, and regardless of their staging, whether it's 1, 2, 3, we say let's do it for all lung cancer diagnosis, and it's hard for them to just say what's 1B, 1A. So we just collect it anyway. So it's definitely more than 50% in my institution, but it will vary according to practice. But I would suggest reflex test is really what we need going forward based on this new indication.
Dr. Che, the group in Springfield chose C, 31 to 50%.
Got it. Yeah, and that's pretty much a real world experience, I would say. So Tagrisso is a targeted therapy targeting EGFR classic mutations, T790 resistant mutation. It does have very low activity against Y, thereby having very favorable toxicity profile. Next slide. So it's a trial that randomized Tagrisso 1:1, 80 milligrams daily versus placebo in this group of patients, stage 1B, 2, 3A. This is per the 7th AJCC staging edition, and 2 classic mutations and MRI, CT scan of brain prior to surgery or randomization was required. And there was maximum interval between surgery and randomization of 10 weeks without adjuvant chemo, 26 weeks with adjuvant chemotherapy. So they did allow adjuvant chemotherapy, and the treatment duration was 3 years. And primary endpoint was disease-free survival. Secondary was disease-free survival in overall population, and overall survival. And the data was released 2 years early as recommended by an independent data monitoring committee due to overwhelming efficacy in resectable diseases. So you will see the data, and it's pretty alarming. But that's how we got approval much sooner than expected. Next slide. So perhaps Dr. can talk about the staging.
Yeah, thank you. So, the AJCC 7th edition staging for non-small cell lung cancer changed to the 8th edition, adopted in this country about 2 years ago now. And the main sort of takeaway points from this is looking at the T stage as related to size. And so if you look at the stage 1B, which for us is anyone that has stage 1B disease or higher, it's referral to medical oncology for discussion of possible adjuvant therapy. So you can see for stage 1B, that's a T2A lesion, so that's greater than 3 centimeters. But then if you look at the next line on that table, T2B being over 4 to, anywhere from 4 to 5 centimeters, that was still stage 1B in the 7th edition. That is now considered 2A. So a 4.5 centimeter tumor, which used to be 1B, is now 2A. And then if you look at the very last line on the table, a tumor that's bigger than 5 centimeters used to be 3A, and now it's 3B. So you can see there's a little bit of upstaging there with the stage 1Bs and the 3As going to the next stage based on the size of tumor. So you have to bear in mind that when you look at the different tumor sizes in the original study, I think that now that for any given tumor size, you're going to have an upstage from 1B to 2A or 3A to 3B. Now we used only the 8th edition of the AJCC, staging for non-small cell lung cancer.
So this is the clinical trial population, Tagrisso group versus placebo, pretty much equally balanced between all the characteristics. and about 1/3 are smokers. Next slide. So this is the result. It's pretty remarkable to see this wide gap between the placebo and Tagrisso arm. So you have the 3-year disease-free survival difference of 78 versus 28, and hazard ratio is 0.17. With any medical oncology trial, this is probably the best hazard ratio you're going to get, 0.17. And that's why they had to report this 2 years earlier than expected. So reducing the risk of recurrence or death by 83%. Next slide. This is the in overall population, which included stage 1B, and still hazard ratio 0.2, with same big difference between 3-year disease-free survival rate of 79% versus 40%. Next slide. So if you look at this graph, all subgroups have equally benefited from use of Tagrisso. And it seems that exon 19 might be benefiting more, but we know in general, the exon 19 group have better prognosis. And whether you got adjuvant chemo or not, these both groups seem to be benefiting from them as well. Next slide. So with prior adjuvant, you can see the graph on the left side. Without the prior adjuvant, you can see the graph on the right side. Both show pretty much big difference, hazard ratio between 0.16 to 0.23. So they both benefited. Next slide. So these are by stage. So we would think at stage 2, 3A, they benefit a lot, but in still stage 1B, you see hazard ratio is still very good, 0.39, with 2-year disease-free survival difference of 88 versus 71. So I say the data tells us that even in stage 1B, this approach is valid. Next slide. So CNS.
Well, if I could just add one thing there.
Yeah.
Sorry, Dr. Che.
Go ahead.
I think that's really important. You know, you had looked at those original reporting of overall survival, looking at stage 2 and stage 3A, and then they also had all patients, so stage 1B, stage 2, and stage 3A. And that's important because in the past, there are many stage 1B patients that, because they're lumped into the general stage 1 category, do not receive referral to adjuvant, you know, for adjuvant therapy with medical oncology. Many surgeons resect the patient, they have a stage 1B, you know, pathologic diagnosis, and that's it. And they don't have any referrals at all. I think this kind of changes the game here and offers a lot of potential options for patients.
Yes, very, very good point. Thank you. Thank you for chiming in. CNS Mets is still a very significant problem for especially lung cancer patients. It's a sanctuary site for Mets. 41% of patients who recur have CNS recurrence. EGFR mutated group have twice the risk of CNS metastasis compared to wild type. And Tagrisso has been continues to show a good blood-brain barrier crossing ability in preclinical and clinical scenarios. So it does a good job in preventing CNS recurrence. Next slide. So this is 1% versus 10% in this very trial. Next slide. And this is the CNS disease-free survival curve. With same hazard ratio of 0.18, even in CNS space. Next slide. The safety, as you can see here, grade 3, 4 toxicity are all single digit. A lot of it is less than 1%. So still very tolerable. Nothing concerning. Nothing not consistent with what we already know. Permanent discontinuation rate was only 11%. Next slide. And here are other AEs that also shows most of them are less than 1%. Next slide. Here is laboratory abnormality. So compared to chemotherapy, this is very tolerable. This is one of the most tolerable drugs, TKIs in medical oncology space, as you can see here. Next slide. Based on the result of the ADIRO trial, how likely is your practice to test more patients with resectable non-small cell lung cancer for EGFR mutation? So you can put anything you want in the chat box, or for me the data is pretty convincing, and I think a lot of practice should now adapt checking EGFR mutation for starting with stage ones.
We got one response, Dr. Che, very likely.
Great.
Okay.
All right. Any input from you, Dr. Lam, about this question?
No, thank you. Yeah, so I was gonna mention this a little bit later when we talk about the multidisciplinary team that we have here. I think we are very spoiled here. The vast majority of biopsies that are done at our facility that are found to be adenocarcinoma then undergo reflex testing. We have a whole mutational panel looking at all possible driver mutations, not just EGFR. Now it's a little bit different when we have referrals from the outside community, biopsies that are done outside of our hospital system. They're often just done biopsies. There's no reflex testing. Sometimes those patients won't get their mutational panel done until after surgery, after the pathologic specimen is examined. But in general, in our institution, we have a very, very high rate of testing, not just for looking at phenotype, not just looking at young, healthy female non-smokers, Asians, but all patients with adenocarcinoma. So I think we're very fortunate, very, very spoiled here.
Great. Thank you. Next slide. Well, safety information. So interstitial lung disease, QT prolongation, cardiomyopathy, not common, but something we should look out for, and it's a reason for permanent discontinuation. Next slide. There are rare side effects as keratitis and many others, but common reactions are really the rash, diarrhea, fatigue, nail changes, and so forth. Next slide. So NCCN right now is recommending molecular testing for patients with resectable stage 1B, 2, 3A, and adjuvant therapy. Osimertinib is listed as the first and only recommendation in this space. Next slide. Yeah, maybe we can talk about this. Maybe Dr. Lam, do you want to start the discussion?
Yeah, so at our institution, Tuesday afternoons, we have our multidisciplinary tumor board for lung and chest masses. And that's all the different divisions and departments, thoracic surgery, pulmonology, medical oncology, radiation oncology, pathology, radiology. And we all get together and we discuss patients that have come through our system, and we try to come up with a group consensus of treatment. And that's not just for complicated stage 2 or stage 3 patients or stage 4. This is also for stage 1 as well. And often it's very, very helpful to have input from everyone involved. And so as I had mentioned before, many of our patients who have biopsies done within our hospital system have EGFR mutations identified if they are there from our molecular panel. Patients that are referred from the outside community, which is a smaller number, do not always have that. And so they often will have their mutational panel done again on the postoperative specimen, on the pathologic specimen. I think it's very important that we have this multidisciplinary discussion beforehand so that patients who we know already have a clinical stage 1B or above disease already are plugged into medical oncology. So they're already aware of it. It's not a surprise when we have a patient that we operate on that has stage 2 or stage 3 disease, and now we refer them for adjuvant therapy in medical oncology who's never heard of them. That's not a good setup. And that's actually a setup to have patients slip through the cracks. So we want a multidisciplinary discussion beforehand so that everyone's on board. We know what the treatment plan is. We know that their plan is going to be surgery and then adjuvant therapy of some kind. So I think that's a very, very good setup. We do go through a lot of patients. It's a 90-minute tumor board every week. There's actually a secondary tumor board that is on Wednesdays as well now, so twice a week. Lots of patients, lots of potential patients that we can help here. Another audience question. So in your practice, if you have a patient that has resectable non-small cell lung cancer and they undergo molecular testing, for example, looking for EGFR mutation, what type of tissue specimen would that testing have come from? Is that from the pre-op biopsy? Is that from the post-operative surgical specimen after their lobectomy or their lung resection? Or do patients not get tested at all? Hopefully it's not C. Hopefully they get tested in some fashion or another.
We've got an A or a B, and then somebody's said C. So
that's okay too. Maybe we can try to change things around the more that this data is disseminated.
There you go.
Okay, I think we can go to the next slide for Dr. Che.
So for testing, we always recommend multi-gene or multiplex panel. The reason is, there are now multiple genes that we need to test, and if you use it for each slide, you're going to run out of tissue very soon. Multi-gene panel may take longer, 5 to 14 days versus 1 to 7 days. However, we are getting more number of genes that needs to be tested for selecting frontline therapy. So this is the way forward. And I've had many cases where NG at next generation panel have picked up what the prior PCR tests have not been able to pick up. So I think we should really think about the comprehensive genomic profiling. Next slide. If a patient with resectable non-small cell lung cancer in your practice undergoes molecular testing, what type of assay would you order? Single gene or multi-gene? Well, in our institution, we always do NGS. We have 161 gene panel. We used to have 22 gene panel, but I would say, knowing what mutation you have at diagnosis, even if it's a resectable disease, will help because a lot of them will have recurrence, and you'll know if this is a recurrence of the same clone or it's a different type of cancer.
Yeah, the vast majority of our patients undergo the multi-gene panel. I very rarely see the single gene assay. That might be from an outside institution. Very, very rarely.
Great. Yes, we can go to next slide.
Okay, so if you've identified that somewhere along this pathway, from the diagnosis to discussion of treatment to the actual surgery and then adjuvant therapy, somewhere along there you need mutational analysis. Somewhere along there you have to try to identify driving mutations that have potential treatments. But then who is going to be the champion to take care of that? Who is responsible for ultimately ordering the tests and then following up? And at what point in that pathway does that happen? And that's not so easy. Some people say, well, pathology should do it because they're the ones that can, when they identify adenocarcinoma, let's say on a surgical specimen, that can then order the testing because they see the diagnosis first. They're the ones that make the diagnosis. Some people will point to either interventional pulmonology or interventional radiology. They're the ones that perform the biopsy. They should follow up on the results, and then they can be the ones who order the testing. There's the nurse navigator who is sort of overall quarterbacks everything and helps to sort of coordinate all the different specialties. They might be a good point person to identify people that need molecular testing. What about the medical oncologists? Aren't they going to be the ones that eventually will prescribe and help to manage the adjuvant therapy? Maybe they should be the ones who kind of oversee all the testing. And then the surgeon, right? The surgeons are the ones that actually take the patient to the operating room and resect them. They put orders in for the pathology, examination of the specimen, maybe they should be the ones to also make sure that patients have an EGFR mutation testing or diagnosis if they're the ones operating on the patient. So there's a lot of different potential places where it can be done. I will say that in looking at discussions with other institutions, it seems that the champion tends to be the medical oncologists, because they are ultimately the ones that are going to be using that information to then manage and prescribe the adjuvant therapy. But this is highly variable based on your institution, and unfortunately another potential for patients slipping through the cracks if there isn't a good team plan on how to manage these patients. Next slide, please. And so in your institution, what percentage of resectable patients with either stage 1, stage 2, or stage 3 disease do you think are currently discussed in a multidisciplinary team fashion or tumor board fashion? Is that less than 10%? Hopefully not. 11 to 30%, 31 to 50, or greater than 50? I would say for our institution, it is definitely greater than 50. The vast majority of our patients are discussed in a multidisciplinary setting. Dr. Che, how is that at your tumor board?
Yeah, I think a lot of early stage are discussed. I guess more than 50% about what adjuvant therapy is appropriate. Yeah, so we tend to discuss almost all cases that adjuvant is required, whether it's EGFR or just yeah.
And I think that's where all tumor boards are heading. Sometimes I participate also in the sarcoma tumor board as well as a GI oncology tumor board. And cancer care is getting so complex, and every single organ system is getting so complex. It really behooves the patient to have a team of different experts contributing to discussion of management.
Agree.
Another question for the audience. In your experience, at what point in this patient's journey are the patients with non-small cell lung cancer referred to medical oncology? Is this immediately after the initial biopsy, once they have a diagnosis of lung cancer, no matter what stage? Is it only after all the staging is done and discussion to see if they're resectable prior to surgery? Or is it post-op after surgery? So at what point do they first get referred to medical oncology? As I mentioned earlier, our patients are discussed at multidisciplinary team before surgery. So before that ever happens, before they ever meet a surgeon. So the ones that have stage 1B and above, we already know about that on the clinical staging. They're already plugged into medical oncology. We're already aware of those patients. So it's not a surprise when they get referred 4 weeks later after surgery to medical oncology. And Dr. Che, how is it at Northwestern?
The same way, yeah. Immediately when we get the diagnosis, we would like to have it upfront. Yeah.
Next slide, please. Dr. Che, I'll let you take this one.
Yeah, I think this slide just emphasizes, probably the best way to do this is, reflex testing, and so that no one drops the ball. And it's, the system is there to ensure that all lung cancer diagnoses will get tested, and preferably the comprehensive profiling. And really, there's a streamlined process of getting that to medical oncology. As soon as the results available, not like we don't have to request that and wait another few days. So I think that will really just play benefiting patients. Yeah, and I think that's pretty self-explanatory. Next slide. What are your institutional processes for molecular testing? So reflex versus test if ordered, test stage 4 only. I guess I myself and Dr. Lam was kind of telling you that reflex testing is what we are doing and what needs to be implemented. But I'm curious to know what other people are doing.
Yeah, I would say it's getting to the point, and sort of we're right on the cutting edge of this, is that this is eventually just going to be routine. Right? That's the hope, is that this is routine additional information. We no longer treat all lung cancer patients the same based on what stage they are, right? It's not that, oh, all squamous cells or adenocarcinoma stage 2B all treated the same. No, this is a little bit more personalized. This is a little bit more based on the biology of the tumor and what specific driver mutations can we find. How can we better tailor the treatment for that specific patient, not just treating all patients the same, because not every single 1B patient is the same, as the data will show.
Great. All right, so this is the summary slide for the Durrell trial. So median disease-free survival in stage 2 and 3A, not reached versus 19.6 months with hazard ratio of 0.17. Stage 1B included, not reached versus 27.5 months with similar hazard ratio of 0.2. So really the disease-free survival benefit was present across different subgroups, including with or without prior adjuvant chemotherapy. The benefit was the same in the CNS recurrence space, and the Tagrisso remained pretty tolerable disease. Majority of adverse events being grade 1 and 2. Next slide. So
yeah. So
yeah.
as I had mentioned before, I think it's very, very important to discuss these patients in a multidisciplinary forum. Rarely we will receive referrals to our thoracic surgery office from outside community primary care doctors who will have a nodule that they find, they biopsy it, they find lung cancer, and they refer straight for surgery. And they skipped every other step: staging, multidisciplinary discussion with pulmonology, mediastinal evaluation. And that's really, because they think that we have to move quickly. And the most important thing is get the cancer out. But we need someone to slow down. And sometimes I'll see those patients with other specialties and discuss it in a multidisciplinary fashion. Sometimes we put a break on the referral and we have them seen and evaluated in our multidisciplinary team prior to heading to surgery. Because I really think you miss out a lot if you just rush people to surgery. As a surgeon, I'm very impatient by nature. I would love to just take everyone to surgery, but I think that does a disservice to the patients. And you certainly want to make sure they're appropriately staged. You want to make sure you have all the available information. You want to make sure that they're plugged into our system so that no one falls through the cracks, and we know adjuvant therapy, if indicated, is going to be available for them, and everyone is on the same page. So I highly encourage everyone to be discussed, especially when it gets more complicated. Stage 1B, definitely stage 2, stage 3s. I think we're really doing patients a disservice to not have them discussed in a multidisciplinary forum. And of course, then with that comes testing. In addition to the traditional imaging testing and mediastinal staging, we also want to make sure that they are appropriately tested for mutational panel to look for potential driver mutations such as EGFR. And as Dr. Che had mentioned, patients that we identify that have EGFR mutations who are then candidates for adjuvant therapy with Tagrisso, they're going to benefit. We know that. We see that in the data, and we see the amazing results compared to a placebo.
Thank you. Echo what you say. So the use of Tagrisso, the standard dose is 80 milligrams daily. And adjuvant indication allows us to use it on up to 3 years, of course, until disease recurrence or unacceptable toxicity. It could be taken with or without food. It can be, even administered through the NG tube when they have any issues with swallowing. Next slide. So these are the adverse events that we need to consider, permanently discontinuing. ILD, QT prolongation, congestive heart failure, there's Stevens-Johnson syndrome. But the rule is, if you get to grade 3, hold it up to 3 weeks. If it gets better to grade 1, you can resume either at 80 or 40. Next slide. And there is an access program you can reach out to if you have any issues with reimbursement. Next slide. All right, so we can take any questions.
So at this time, please, if you do have any questions, please put them in the Q&A, and then we will be more than happy to answer those questions for you. Keep in mind that we can only answer on-label questions. Gina, do we have any questions at all in the chat or in the Q&A?
No, we have no questions right now.
And if anybody wanted to ask something live too, you can let us know through the chat, and we'd be very happy to unmute your line so you can ask a live question. Well, I guess we have none at this time, so I would like to thank Dr. Che and Dr. Lamb for their presentation. We really appreciate all your insights. And also thank you all for attending this evening. And this will conclude our program for tonight. So thanks again, and everybody have a wonderful evening.
Also, thank you, Kathy and Gabby.
Thank you, Dr. Lamb. Thank you, Dr. Che.
Thank you, everyone.